Hey, welcome to everyone to the first AFSRA webinar on point of care ultrasound. I see friends from Africa, from all over the world, from Europe, from Australia, from South Africa. Welcome to everyone. I'm Francois Retief, anesthesiologist from Cape Town, South Africa, and part of the African Society of Regional Anesthesia. We are honored to have two very special guest speakers with us tonight. Both are very well recognized and published experts in the field of point of care ultrasound. First, a good friend, Rosie Hogg. She's consultant anesthetist from Belfast in the UK. She has a postgraduate MD from Queen's University and also spent time in Pennsylvania, the university. Her research and interests focus around point of care ultrasound, regional anesthesia, and patient-centered outcomes. Then Ari Kalagara is assistant professor at the Mayo Clinic, Jacksonville, Florida. He's currently the chair of the ASRA Pain Medicine POCUS courses and has quite a remarkable research and teaching record. We are very thankful to have you both with us tonight and for the sharing of your expertise. The mission of the African Society of Regional Anesthesia and Pain Therapy is to encourage and promote excellence in regional anesthesia and pain in the fields of education, research, and practice in Africa. As part of this, AFSRA endeavors to host monthly webinars in the future with international experts like the two we have here tonight, and at international standards, but applied to the diverse context of Africa. The webinars will alternate between English and French. So today is the first one in English. I will be the moderator for the session. So I'll just give a short introduction and then leave the talking to our experts. Please write your questions as we go along in the Q&A section on the Zoom app at the bottom. We'll have time for discussion at the end, and we'll attend to the posted questions then. You're also welcome to use the chat section during the meeting for comments to the group. So what is POCUS? Point of care ultrasound has become an essential bedside tool in the last 2 decades. Like the stethoscope is an ear to hear what's going on inside the body, the ultrasound is our eyes. For the low middle income countries and Africa, POCUS is especially applicable because it has become very affordable. It decreases the reliance on expensive special investigations like CT and MRI, which is often not available. It is much quicker doing at the bedside or in theatre, meaning that it leads to earlier diagnosis and earlier treatment and therefore better outcomes and consequent lower costs. Ultrasound may prevent several complications. And lastly, although there are very complicated aspects to POCUS, the basics is really not difficult and can be mastered by any healthcare provider without special training. In my view, the way to learn POCUS is simply to get a probe and make it part of every step of your journey with the patient. So during the pre-op visit, we may be checking the patient's heart for systolic and diastolic function, or look for valve abnormalities or effusions. Or we may look at the lungs, for example, for pneumonia or pulmonary edema or effusions. In trauma, we might be looking for lung contusion or pneumothorax or free fluid in the chest or abdomen. We may be evaluating the stomach content for the reflux risk. In theatre, we can use it for all our lines and all our regional procedures. We can check if we caused the injury to a blood vessel or a pneumothorax or block the phrenic nerve. And I often use ultrasound during intubation to instantly see whether the trachea or the esophagus is intubated. That's especially useful when the registrars are intubating. Also, we can check whether the intratracheal tube cuff is positioned correctly and monitor for bilateral ventilation. We can mark the landmarks for front of neck access for difficult airway. During anesthesia, transthoracic echo is an additional hemodynamic monitor. And for troubleshooting post-operatively, Rosie has an excellent example for us, which you will see in a moment. Over to Rosie.
Thanks so much, Francois. Just going to share my screen now. It's an absolute honor to be here this evening, and I hope you can all see that okay. So my name's Rosie Hogg, and I'm based here in Belfast in Northern Ireland, which is strangely warm at the minute. And believe me, that's very unusual for Northern Ireland. So it's an absolute honour to be here with all of you tonight. And I want to extend my thanks to everybody in the African Society of Regional Anaesthesia and Pain Medicine for this very kind invite. So I just have one declaration of interest, and that's that I do a little bit of education work for GE Healthcare, but that's not going to affect anything we're talking about tonight. So when we think about POCUS, I want you to think a little bit about Batman. So you as anesthesiologists and part of the anesthesiology team, you are exactly like a superhero. So when everything goes terribly wrong, nobody knows who you are, nobody knows what we really do. But when things go terribly wrong, the answer always is to call us along. So that's great. And we have all sorts of amazing clinical skills. But what if you could use the ultrasound probe that you have there? Maybe you're doing your regional anesthesia block. And how come that can add to your clinical practice? Okay, so we're going to talk about something really clinical. And first off, let's take a scenario. So you've just anesthetized this lady. She's had some complex shoulder surgery. So you've done an interscalene block. She's had a general anesthetic as well, and the surgery's gone brilliantly. But the patient is now out in the post-anesthesia area. And the nurses come to say to you that you're a bit worried that she's feeling very short of breath. So what are you going to do? Obviously, in this scenario, you're going to grab your stethoscope. And then you might consider, do I do a chest x-ray, or what else could I do? But it can be quite difficult moving patients to get chest x-ray, or depending on where you are, you may not have all the resources at your fingertips. But if you've just used ultrasound to do your block, actually you do have the resources right there at your fingertips. So let's think a little bit about this. Now, obviously you've done a nerve block, so the surgeon will be blaming you and saying, oh, it's obviously diaphragmatic paralysis. That's why the patient is short of breath. But actually, there's all sorts of other reasons why this patient could be short of breath after this procedure. So you have done a block. There's a possibility of a pneumothorax. When you ask a little bit more about this patient, you remember that actually she's got ischemic heart disease. She's a smoker. She's got COPD. So there's lots of other reasons that she could be short of breath. She could have gone into heart failure and have interstitial syndrome. She could have a pleural effusion that you didn't diagnose before. She could have an underlying infective process that wasn't evident in the preoperative period. She could just have some atelectasis and collapse after the general anesthetic. Or indeed, your surgeon may be right and she may have diaphragmatic paralysis. So what if you had a tool at the bedside that would let you diagnose and go through all of these differential diagnoses? And you do. So this is where lung point of care ultrasound comes into play. The great thing is you can use pretty much any probe that you have. For me, I usually recommend using a curvilinear probe or a phased array probe, but a high frequency linear probe can be really, really helpful for looking at the pleura. What kind of position do you want the patient in? Well, most patients who are short of breath are going to want to be sitting up in a 45 or 60-degree angle. So wherever's most comfortable for the patient. But remember, you want to be scanning in a number of different areas. So what do we see when we place the probe on? So if you're scanning here in the anterior chest, this is the image that you're looking for. So you can see here that you see a bright white hyperechoic line moving back and forward. And that's the pleura, okay? So you can see it moving back and forward, and that's the visceral and parietal pleura sliding across one another. You can see on either side here that there's a rib shadow, and it's really, really important to get this image. And the reason for that is, as you can see, there are white lines above the pleura, and those are fascial planes. And if you've popped your probe on and you're a little bit shallow, then you might be confused about which is the actual pleural line. So this bat sign is what you want to get. Below that image, you can see some white lines as well. I'm not sure why it's going a little bit pixelated like that, but those white lines below are what's known as A lines. So those are artifacts. Basically, it's your machine saying, oh my goodness, everything below the pleural line, I'm not sure what it is. And that's because when ultrasound beam meets air, basically it scatters all over the place. So these are really actually quite helpful, because what these artifacts do is that they tell us that there is air below the pleural line. but they won't tell you whether that air is actually there in inflated lung or if it's there in a pneumothorax. But these A lines do disperse if there's interstitial fluid. So you'll see them evaporate whenever there's any kind of interstitial fluid or pulmonary edema. What else do you want to look for? So this is what's known as the lung pulse. So this is the pulsation of the cardiac cycle moving through aerated lung all the way up to the pleura. So when you see this, you know that you've got aerated lung and a fully inflated lung. This is also a really, really useful thing to look for just in normal clinical practice, because if you've got aerated lung, but you're not actually ventilating, you're not going to get that sliding of the pleural line that we saw before. So it's very helpful if you've got a right bronchial intubation, or if you're trying to gauge where to put your tube in a pediatric patient, or in fact, if you're using a double lumen tube and you don't have a bronchoscope handy. Again, we can see those artifacts of the A lines below the pleura. And this is another image of normal. So here we're scanning down towards the base of the chest and the dependent part of the lung. So you'd be scanning here in the mid to the posterior clavicular line for starters. You can see here on the right-hand side, we have the liver. There's a white jagged line behind that, and that's the spine. And it's really important to see this because, as you can see with the white hyperechoic line of the diaphragm above the liver, you don't see that jagged line above the diaphragm. And that's because, again, you've got lovely aerated lung there and it's obliterating your view. What you see coming across the screen there is, again, aerated lung. And this is what's known as the curtain sign. So this is a normal image of aerated lung right down to the base of the lung. This is really, really important because quite often people say, oh, I can't see anything when I scan the lungs. And that's actually good. If you see really, really good images, you know you've got some pathology there. So let's move on to look at some of that pathology. One of the first things we want to rule out is a pneumothorax. So with this, basically you see what's known as the lung point. This is the point at which the visceral and parietal pleura separate. And as you can see here, you've got lung sliding up into a point and then just a plain white line, no lung sliding. And this is really, really critical. In the past, we would maybe have said put M-mode down through the pleura to assess. And many of you will have heard of the barcode sign, the seashore sign, where you got the non-moving chest wall, you got the lines on M-mode, and then with the motion of the pleura, it looked like a sandy beach. The problem with this, and the reason that we don't teach it quite so much anymore, is that if you can imagine with a patient with a pneumothorax, they're actually moving their chest up and down quite a lot. And unfortunately, that means that it can be quite confusing if you put M-mode down through this. So we very much recommend looking for that absent lung sliding, as you can see in this scan. Again, you're looking for the absent lung pulse as well, because the pleura will not be attached together, so you won't get that transmission of the cardiac cycle. Again, here you can see there's lung sliding coming in and out of the image. What I want to point out to you in this image in particular is, do you see the way the A lines are still there? So those artifacts are still there below the pleura. So remember that having A lines doesn't rule out having a pneumothorax. Do people say, does this matter? Well, actually, it's much more sensitive and specific using the point of care lung ultrasound than it is using a chest x-ray, particularly for smaller pneumothoraces. And if you can find that lung point, you can actually assess the size of your pneumothorax as well. So I would say this is really the modality we should be using looking for pneumothoraces, much better than compared to chest x-rays. So what else can we look for? Well, interstitial syndrome, particularly pulmonary edema, but there's lots and lots of reasons that you might have fluid on your lungs. Here we're looking for a different sign. Again, another artifact. So these are known as B lines. These B lines come right from the pleural line all the way down to the bottom of the screen. In a normal rib space in a dependent area at the base of the lung, you might see one B line. But to be honest, if you're getting 2 or 3, that means that there's pathology there. In this scan, you can see multiple B lines, so there's obviously pathology and an increase in interstitial fluid. And what does it mean? So you can see here, it's really de-aeration of the lung. So 0 there, there's none. We can see our A lines as normal. Again, moving on to 1, there's B lines. Usually over 2 to 3 in each rib space would be concerning for pathology. As you progress on, these become confluent, and basically each rib space just has a solid B line. And if you can see there on image number 3, eventually the lung just gets so wet, it almost looks like a solid organ. It's really important to remember when you're doing lung ultrasound, don't just scan on one side or in one area. There are lots of different things that tell you should scan in 8 areas, 16 areas, 32 areas. What I would say is just generally scan around and make sure that you look for pathology in a number of different areas. And don't forget the posterior chest as well if you can. So if you see localized or unilateral B lines, they're more likely to be lung contusion or a single-side pneumonia or perhaps a tumor. But again, if it's diffuse and bilateral, your diagnosis would be leaning more towards pulmonary edema, ARDS, or bilateral pneumonia, or some kind of infiltrated disease that's on both sides of the lungs. So again, we're going through these differential diagnoses a little bit quickly, but it's because we want to have lots of time at the end to have some questions as well. I always like to say to people, if you see a really, really nice image on lung ultrasound, you've definitely got pathology. And that's what you can see here. Here are 2 rather extreme examples of large pleural effusions. So the first thing that's noticeable is that the image is really, really nice. So there on the left, you can see essentially a large pleural effusion, and you can see the diaphragm very clearly, and you can see the liver below the diaphragm. In fact, on the right-hand side there, you can see fluid both above and below the diaphragm as there's ascites. The other thing to look out for is the spine sign. Again, on the right, we can see the white spine sign right above the diaphragm, so we know there must be some pathology there. If you're looking at the image on the left, you can see something there flopping around inside the pleural effusion. And that's sometimes called the lung monster, the lung nest monster, or the jellyfish sign, all rather strange names for it. But basically what that is, it's atelectatic collapsed lung moving around in the pleural effusion. What's interesting that you can see there is you can see some white lines as well, and they're air bronchograms. If they don't move a lot, they're called static air bronchograms, and that's a sign of atelectasis whenever you've got some fluid in collapsed lung. If they move more, they're called dynamic air bronchograms, and we can show you an image of that in a moment, but they're more likely to be associated with an infective process. The important thing to remember about pleural effusions is even 50 mils of fluid is evident on lung ultrasound, so it's really, really easy to make that diagnosis. So what about the inflammatory processes? Here are those dynamic air bronchograms that we were talking about before. So you can see the bronchial tree, and you can see the movement of infective fluid moving back and forward within the pulmonary tree. Again, if they're static such as that, that would be more of an atelectatic picture. And what else does infection look like? Here's something that's known as the shred sign. So most pneumonias are right up at the pleural line there, and you'll see this ragged edge. We saw this all the time in COVID. So basically, it's that really inflammatory process affecting the lung. So it's important to check in many different areas, especially if you've heard crackles or something when you're listening with your stethoscope, to look for these signs. And this is known as the shred sign associated with the pneumonia. And sometimes this gets so bad, as you can see here, it almost looks like you've got a solid organ above the diaphragm. And again, there we've got a small pleural effusion around. So it just goes to show that you can diagnose so many different things just by using the ultrasound scan that you have there whenever you're doing your regional anesthesia. So what about diaphragmatic paralysis? Now, I'm not going to cover this in a lot of detail, but it's actually a really interesting way to think about looking at the diaphragm. And also it's very helpful to assess your patients before you actually do your block. There are a number of different ways to do it. This is probably one of the more traditional ways, using the curvilinear probe at the costal margin, looking up using the liver as an acoustic window, and putting M mode on across the diaphragm. So you'd ask the patient to take large, deep breaths in, and as the diaphragm moves up and down towards you, you'll get this movement on the M mode screen that you can see on the bottom right there. You can again do the sniff test, and you'll see a spike in whenever you use M mode. I quite like this mode, but unfortunately it can be very challenging to get a really good image if the patient is very obese. And again, it can be a little bit uncomfortable for the patient. So one of the ways that I mostly do diaphragmatic ultrasound now is with a linear probe. And I look for here, which is the zone of apposition. So that's basically where the dome of the diaphragm meets the more muscular area at the side of the diaphragm. And here I use a linear probe. I'm going to put it on around about the 7th, 8th intercostal space in the mid-axillary line. And what you're looking for again is you're going to be looking for, as the lung comes down, you'll see pleura. And you're going to start to see something that looks slightly different. So it's highlighted here in yellow. And this is the diaphragm. And this is just in normal breathing. And you'll see it has a pleural and a peritoneal layer. And also quite often looks like it's got a little bit of striations inside. And if you look to the left-hand side, you can see it thickening and thinning with normal inspiration. The place that I like to really look for it is actually just where the lung comes down. So you'll see coming in on the left-hand side, the pleura coming in and out again. And if you see the diaphragm there again, you see the bright white lines and the striations in the center. This thickens up with inspiration and then thins out with expiration. And what you can do is you can measure this, or you can even just eyeball it. Another good thing to see is the actual excursion of how many rib spaces really the lungs are coming down and up. Because as you can imagine, if you've got diaphragmatic paralysis, you're going to get very little excursion. This is actually quite easy to see even on the largest patients. And I really like it as a quick way to just look and assess diaphragmatic thickening in a patient before I consider doing a block. Because if I look and see that there isn't really that doubling in size of the diaphragm, I would be concerned about doing something like an interscaling block where I know I would get phrenic paralysis. So again, a quick and easy way just to assess the diaphragm. Does it really matter? Well, there is more and more evidence coming out now to say it does improve outcomes. And mainly it's reducing that time to making the diagnosis and reducing the time to actually starting the treatment. And for me in my clinical practice, what I really like to do as well is that I can scan, do a treatment, and then I can scan again to see if things are improving. Of course, if you have the facilities to do chest x-rays, CT scans, that's all fantastic. But not all of us have that right there on our day-to-day practice. But many people do have ultrasounds readily available. And this will just give you so much information. And in some cases, it's better information than you might get from a chest x-ray. Again, this is a really nice study from a few years ago that looked at the sort of comparison between lung ultrasound and then patients having a CT. And actually, it was really close in agreement between both lung ultrasound and CT scan for atelectasis, pneumothorax, and pleural effusion, which is what we've described already. Finally, again, I just want to talk to you about that right bronchial intubation. I don't know about you, but in a busy OR, it can be really, really hard to hear breath sounds, especially in patients who've maybe got some pre-existing pathology. So again, you can use your ultrasound probe to find out exactly where your tube is. And actually, in this study, the correct identification of tracheal versus bronchial intubation was only 62% in the auscultation group, but 95% in the ultrasound group. So really, really helpful in those challenging environments. I like this card. It's from a paper by Elena Segura-Grau, which is just a really nice aid memoir to remind you what to look for whenever you're doing lung ultrasound and to take it step by step. So very quickly, towards the end of my talk, I'm going to talk a little bit about airway ultrasound. Now, again, we've got a challenging patient here. You've been called down to the ED. You've got a patient who's come in with a swollen airway. They're going to need to go to the OR for some treatment. And you're slightly concerned. It's the middle of the night. You're on your own. And you're thinking, will I be able to intubate this patient? And if I can't intubate this patient, what am I going to do? So failed intubation and failed oxygenation in our patients is one of our biggest concerns as anesthesiologists, and rightly so, because the mortality associated with this is very high. We all know how to do a scalpel cricothyroidotomy, but the problem is we all think that we can just feel for the cricothyroid membrane and that it'll be really easy to do. But studies have shown, unfortunately, we're really, really bad at finding where the cricothyroid membrane is. We can be anything 2 to 3 centimeters away from where it should be. Whereas with ultrasound, you know exactly where you are straight away. And this isn't just in everyday patients. Obviously, in obstetric patients, we're very, very concerned about their airways as well. And again, as patients are getting larger, the distance between the skin and cricothyroid membrane increases and increases. So imagine if you had a way to be able to identify exactly where the cricothyroid membrane is. And you can do this with airway ultrasound very easily. I really like this paper from a couple of years ago from the BJA that basically said, if you position your patient in full extension, mark your cricothyroid membrane with your ultrasound, no matter what you do with the head and moving it all around, once you go back into that full extension position, your mark will be exactly where you need to be. So this is a preemptive thing to do. So I would say you scan the patient before you try to do any intubation whatsoever, and just have that mark. So hopefully you won't need to use it, but if you do need to use it, it's there and readily available. So how do we do it? Well, you start off with a transverse scan, start under the chin and you locate the hyoid bone. And then you start to scan down the neck. First thing you'll see is the epiglottis. And then as you continue to scan, you're looking for a triangular structure. This is the thyroid cartilage. And as you scan down, then what you're going to see after your thyroid cartilage is a bright white hyperachoic membrane. And this is the air mucosal interface just under the cricothyroid membrane. As you scan further down, you'll see a more horseshoe-shaped cricoid cartilage. And then following on down from that, what you're going to see after that is the thyroid coming into view, and then you'll see the tracheal rings. Now, this is a fantastic video that comes from the ASRA POCUS Spotlight series. And honestly, I've put a QR code there for you. There are so many absolutely amazing videos, teachings, everything associated with POCUS. And it's one of the places I would say go if you want to learn point of care ultrasound, because you've got absolutely worldwide experts giving you the best advice, and videos such as this, which are so helpful to take you through step by step. The next thing you want to do is turn your probe 90 degrees and do a longitudinal scan. So here this looks a little bit confusing, but what you're looking for are what is known as the string of pearls. So those are the tracheal rings. So those are shown here in green. The pink line behind, again, is the air mucosal interface, and everything below that is air in the trachea, and it sort of destroys your image. You can see the cricoid cartilage there in yellow and the thyroid cartilage in blue with the cricothyroid membrane in between. What's really helpful about this is you can put a probe, maybe a blunt needle or something like that, underneath your ultrasound and mark where the center is in your cricothyroid membrane. So you've located essentially an X marks the spot by doing your transverse scan and your longitudinal scan. Does it really matter which scan that you do? Well, actually, the transverse scan is probably faster and a little bit easier to do to be able to identify the cricothyroid membrane. And for me, I think that's because you're going down through in a very systematic way and locating your tracheal, the trachea, and then your thyroid cartilage and your cricoid cartilage. So you're able to identify all of those things really, really easily. The one thing I would say is it's really important to do this beforehand, and not just to be able to locate the cricothyroid membrane. This is a really interesting video from Harry and his team in the Mayo Clinic in Jacksonville. It was published as a case report. And I just want to show you exactly, again, there we're doing our lovely transverse scan. And what you see coming up now, just as you go down towards the trachea, is a large innominate artery that's lying right in front of the trachea. And here you can see it with Doppler on. And the reason I'm showing you this is that it's important even just not to locate the cricothyroid membrane, but also locate exactly where you would want to do your incision, because quite often there are small arteries there. And the last thing you want to happen in the middle of doing a front of neck access is to have excessive bleeding. So again, this scan not only tells you where the cricothyroid membrane is, but where any other dangerous structures might be. What else can you use airway ultrasound for? So this is an image with the esophagus there just to the left of the trachea. So I sometimes use it in conjunction with gastric ultrasound if you've got a challenging NG tube to be able to identify exactly where your tube is going and that you're sure that it's definitely down in the esophagus. I don't routinely use it, however, for identifying if your tube is an esophageal intubation or not. For me, if you have many people and you're doing a complex airway, you could have somebody manning the ultrasound probe, but it's certainly not something that I would recommend picking up if you're concerned that you've got an esophageal intubation or not. But if you've got a planned complex airway and you've got somebody to help you, it can be really, really useful like this. This is what's known as the double bubble sign. So in summary, That is a whistle-stop tour through lung ultrasound, diaphragmatic ultrasound, and airway ultrasound. For me, perioperative POCUS is an absolutely critical part of any anesthesiologist skill set. If it's something that you haven't done before, I can highly recommend starting. There's so many things online, there's so many courses that we now run to be able to get you started. But the most important thing to remember is that as a regional anesthesiologist, you're already way ahead of other people in doing POCUS because you're used to using the probe. But honestly, it will improve your clinical skills so much and improve outcomes for your patients. So all that's left for me to say is a huge thank you to everybody for listening today, and also a thank you to the African Society for inviting us along. I'm really looking forward to hearing your questions shortly, and I'll hand over to Harry.
Thank you so much, Rosie. That was excellent as always. Beautiful images, and I like how you show what everything in the screen is, not only the pattern that we're looking for, and also how you draw it through to a case, so the clinical value. Everyone, please post questions, and we only have one question this far. And next up is Hari Kalagara, who will be presenting cardiac and hemodynamic ultrasound, as well as gastric content. Thank you, Hari.
Thank you. Can I share my screen?
Yes, please.
Okay, you are able to see that, right? Perfect. Welcome all. Good evening, good morning, wherever you are. I'm Hari Kalagara. I'm from Mayo Clinic, Jacksonville, USA. So thank you for the AFSRA for this wonderful initiative, starting with POCUS in perioperative care. And special thanks to Mohammed and Franco for doing this. So pretty much I'm going to talk about the gastric ultrasound and circulation heart. So I kept the title very interestingly as ABC of POCUS. I know it's hard to talk after Rosie, so that's where I'm in a tight situation now, but I'll try my best. So being an anesthesiologist or in the perioperative arena, always you think of ABC. If you do the best with ABC using ultrasound, you never end up in a disability. So I always say, whenever you start using POCUS, think of ABC. So my catch points here are, what is A? I'm going to talk about how to prevent aspiration. So I took airway preventing aspiration as A, and hemodynamics and circulation as a cardiac ultrasound. I have nothing to disclose, except I do chair the ASRA POCUS courses, and I'm very biased for the ultrasound. If I speak something, you might see my passion and motivation behind it. Other than that, nothing, no industry funding or anything. So my objectives will be very simple today. I'm going to talk about why we need to do each point of care ultrasound, when they are useful, how to do it, how can you gain some key advantages using these specific modalities. Coming to A, or like the gastric ultrasound, why do we need to do it? Okay, it's basically one key important thing is to prevent aspiration. If you didn't see an aspiration in your career, I always say my golden words, you didn't have done enough general anesthesia, period. You will see one day, the day will come. Okay, so be humble. Every day as you practice, it will teach you. So our important is to stratify the risk of aspiration. And whenever you think some of the NPO guidelines are unreliable, you don't know the fasting status of the patient, that's where we tend to use gastric ultrasound to prevent aspiration. And you all know this NAP4 study being done by the Royal College of Anesthesiologists. Very highlighting features in this one are still aspiration accounts for 50% of anesthesia-related deaths, half of them, and 20% still the common cause of death. So it is a known event, it happens. Okay, what is the biggest message from this NAP4 study the Royal College put forth? Most of the anesthesiologists or whoever does the airway, are doing incomplete assessment of aspiration risk. That means we are failing to assess who is at risk. And second thing, we are failing at doing the proper things when we identify the patients at aspiration risk. So we all know, I don't know how many of you think of it, when we go see a patient in the perioperative period, the first thing or the commonest or the one question we always ask is, when did you eat? When did you eat? We all behave like our grandmas. Fascinating to feed people or relatives. But that's a problem for us in perioperative. Why? Fasting guidelines are different in different countries. Usually, if you see in Europe and other places, it's 6 hours for solids, but in United States, it's 8 hours. So, and now the fasting guidelines are till you come. So, a lot of variability, and most of these fasting guidelines are reliable for healthy patients. But what you see in the perioperative period are not the healthy patients. And when you see patients with diabetes or hepatic dysfunction or other problems, they are not the same. So they say exercise caution in those patients, but how do you do when patients have any other significant comorbidities which delay gastric emptying, or when you have a patient with unreliable NPO status, or when you have patients who are encephalopathic, who cannot communicate, who are also dementic, they cannot communicate, how do you know what they have, when did they last had? So these are the dilemmas that you encounter in your clinical practice. Said that when you have an elective patient, competent patient that being fasted, you don't need to. So this is all for the patients which are beyond our limits. So I'll go through very simply. It is one of the easiest point of care ultrasound modalities to learn. You see, you learn, you just get it through. So for adults, we commonly use a curvilinear probe. We do the patients in supine and right lateral decubitus positions. Always right lateral RLD is the most important and the key position for final thing. So that's why I kept in red mark. So what are the sonoanatomy? You put the probe in the subcostal xiphisternum in the parasagittal orientation. And the key structures that you want to look here are the tip of the liver, lobe of the liver. Then you are looking for your aorta, and then you are aiming to look for your gastric antrum. So you look for your rectus muscle, liver, abdominal aorta, and you look for your gastric antrum. It's very important to look for the aorta, then only you know you are looking for the antrum. If you look for something else, it could not be a gastric antrum. So that is a key landmark we always aim to focus. Sometimes you might see an IVC instead of aorta and you can cut the antrum, but sometimes it might be already through the pylorus. So just be careful what you are looking. How to identify the antrum is very, very important, because the false positives and false negatives come if you don't recognize your sonoanatomy very well. So that's the key is first know how to identify the structure that needs to be identified. But then when you put your probe, what are the things that you are looking? So first thing, as I showed you, is you look for your gastric antrum. You can do a qualitative and quantitative assessments, both of them. So you can look for your gastric antrum. How is there is it empty? Is there any liquids or is there solids? Then if it comes to liquids, you can quantify how much liquid is there. Is it normal or abnormal? We don't use for gastric function a lot, but other people use it. And when I say the clipping, I do the clipping for 30 seconds to see the gastric peristalsis and gastric function to rule out gastroparesis. So that's beyond our talk today. If you look at this, it's very easy. You see typical 4 sonographic patterns when you see a gastric antrum with an ultrasound. So the first one onto the left and to the top is the empty gastric antrum. See the liver, see the aorta, and see the empty antrum. It looks like a bullseye. It's very small, the thick walls of the mucosa. Then you come to the right upper quadrant, then you see the antrum distended and dilated, and with all the white stuff inside it. It is a classic late solid. So you see this one here. And you come to the left lower one, number C, you see the antrum here. You can't even see anything in the posterior wall. You can't even see the aorta. You can't even see the posterior wall of the antrum. It is all like a frosted glass, thick layer of air on the top of the anterior wall. It is classic for early solids. So this is for early solids. And coming to D on the right, the lower hand, you see that now the antrum distended, dilated, and with all the hypoechoic content. So this is a fluid-filled antrum. So these are the classic four things you see: empty, early solids, late solids, and liquids. How do we grade them? So usually you look at the gastric antrum. If it is completely empty, we say it is a low risk. If you have some clear liquids, you turn them right lateral and you quantify them, how much liquids they have. Usually we say if it is less than 1.5 mils per kilo, that is below the basal gastric secretions, that is grade 1. So grade 0 and grade 1 are either empty or less than 1.5 mils per kilo, you are safe enough to proceed. What is high risk? Anytime you see a solid, either early or late, you're done. It's a solid, you're high risk. You don't even need to turn right lateral, but sometimes it's very hard to know in the supine if it is air or a solid, so we turn right lateral even for solids. And second thing, don't ever assume the antrum is especially with fluids, unless you turn right lateral in a dependent position, you cannot say you have completed your quantitative assessment. You have to turn to the right lateral to make all the things accumulate into the antrum and assess. Then if it is more than 1.5 mils kilo, it is grade 2. So these two are high risk. Grade 0 and grade 1 are low risk. Very simple. You put your probe, you see what you're doing, turn right lateral, you just know, is it empty? Is it less fluid or more fluid or solid? So those two will go to the high risk. What are the other ways to calculate the gastric volume? As I said, the volume is usually 1.5 mils per kilo. Less than that is normal. So there is a unique formula that you can use this formula, plug in all the numbers. So I don't want to go too much. The important thing is, once you do the gastric scanning, freeze the image in the right lateral decubitus and then get this cross-sectional area. So nicely include the walls and get this cross-sectional area. Once you get this cross-sectional area, what you can do is you can use this normogram. So all these things are taken from gastricultrasound.org. Beautiful website. You can self-learn. You can do anything from this, just from this website. So what you do is you take your cross-sectional area. Suppose it's a cross-sectional area of 6, you got it. Look at the age of the patient around 40. If this is around 63, that means it is on the green box, then you know you are in the safe limit. So you measure the cross-section area, you put the age, then you know what cross-sectional area corresponds to which safe. Then you got a cross-sectional area of 10 for a patient of age of 30, okay? Then you know, okay, my cross-section area is too large for this agent, and this volume comes into the out of the green zone, then you know it is a high risk. So anytime you see these gastric volumes in the green, safer, it is out, it's not, it is a high risk. The easy thing to remember, I always say, is anytime cross-section area less than 6, given for any age, you're usually in a safe zone. If the cross-section area is more than 10, you're high risk. Between 6 and 10, I try to look the chart for benefit of doubt. So 6 and 10 are the good cutoff numbers. The recent studies published by Anahi Parlas clearly showed 10 is a good cutoff for the high-risk cases. You can do even in children. Only difference is you use a linear probe because the depth is less and you can get a good resolution. You can do in pregnant patients with a curvilinear probe. You can use in any group of populations as long as you use the same technique and things. Basically, I want to emphasize today, why is gastric ultrasound becoming more popular? Just because of these new drugs now. If you see anywhere, it is the most popular drug being used now. Okay, it's like the top 3, GLP-1 drugs. Okay, why are they being used? They are being used for type 2 diabetes and most importantly, weight loss and obesity. We all are fascinated not to exercise, eat more, just use drugs. Okay, that's where we end up. And this is one of the first case reports published by Anesthesia Patient Safety Foundation that highlighted, okay, what's happening with these drugs. They're good in many aspects, but they're very scary for us in the perioperative arena. Aspiration risk, increased residual gastric contents is a serious problem when the patients are in GLP-1 drugs, especially high doses, recently started ones. This is like a serious problem. So this became a red flag. Everybody are panicking, what to do. So anyone is interested, tomorrow I'm giving a big grand rounds talk in Mayo Clinic about this talk. I can share you the presentations and talks later on. So what to do? We don't have any clear idea when to stop, what to do, how long to fast. So only thing the American Society of Anesthesiologists in 2023 came up with some guidance regarding this GLP-1s and perioperative care is use gastric ultrasound. If you see the latest guidelines published across the worldwide regarding the GLP-1, one unique common thing to all these guidelines is use of gastric ultrasound. Everywhere that word is there, that is a mention for gastric ultrasound. So time has come for us to know, to learn, and use. As you are using stethoscope for your other things, it is becoming a tool for you to risk stratify aspiration. So recently we did this big narrative review from the American Society of Regional Anesthesia. How else or where else can we use the gastric ultrasound in medically complex patients? Please see this paper. We reviewed into conditions like pregnancy, obesity, diabetes, GERD, emergency care, and even including GLP-1. So because the time we did this paper, studies were very limited on GLP-1, so we supported the evidence. But in future, with more studies coming up, it will be a full support, my assumption is. So this is where even we looked into and put our proposals. So I just want to quiz you. So what is this video looks like? So this is a classic video with a solid contents in the gastric antrum. You kept the probe, you took a 10 seconds to 50 seconds clip, and you identify the liver, you see the gastric antrum, and you see all the white stuff. So it's so easy, you know what is happening to the patient now, like within 10 to 30 seconds. These are a few examples of GLP-1 patients who have been fasted more than 12 to 14 hours, came to the perioperative area, and our protocol is we scan all of them, means with a GLP-1. So these are all the cases with full stomach. We published this case series in POCUS journal, you can look at it. So these are a few examples how your fasting of normal hours doesn't help you at all. Patient is competent, gave a history, but nothing has helped you until you looked inside what is there. So very scary. If you see patients with GLP-1, you will be able to see one of these scans during your process of learning. And so my take-home message is use gastric or point of care ultrasound when you're unsure, when you think the patient will be high risk, or when you want to prevent aspiration. So you see low risk, proceed, high risk, delay or cancel, or secure the airway. You don't want to do high-risk cases with sedation or without a protected airway. That's the key message. Don't do things when you think an high risk with an unprotected airway. So our goal here is aspiration prevention and safe anesthesia. I don't want to propose how you do an airway with rapid sequence or anything. That's up to you. So key aim is identify these patients with the gastric ultrasound, then propose the best safety measures to prevent aspiration. So Rosie has talked about the lung ultrasound, right? To do a lung ultrasound, you need to have a non-aspirated patients and you need to have a heart to see the lungs. And Rosie has a luxury of seeing two lungs, but here I have only one gastric antrum, only one heart. So be careful, A and C gets the priority. So coming to a few things coming to the cardiac ultrasound. So I love this diagram a lot because in the perioperative care, the two important things I always say is we are worried about the hypotension and dyspnea, respiratory failure. So two things we are always worried to know what to do, what not to do, especially hypotension, so common. You see all the time with your anesthesia career. So unless you put a probe and look what exactly is happening, you don't know what you're helping or you're really killing. So that's I like this diagram. Why is it important to do a cardiac ultrasound? important thing is to look at the cardiac function. So basic important things. Valvular, is there any valvular pathology? How do I know, is there good enough volume? Is there an effusion around the heart? How is the right ventricle doing? My basic mnemonic is, I always say 5 Fs. Is there a fluid around the heart? How is the heart doing? How is the function? How is the filling? So these are the things. Then when you are putting a probe, looking for causes of hypotension, you need to think yourself around the heart, where could be the problem? How can I diagnose? When doing any point of care ultrasound, we always insist people using the IAM framework. That means, what is the indication? How do we acquire the images? How do you interpret, and how do you medically manage? This is a unique, good way of starting your POCUS learning, even for documentation and everything. Coming to cardiac POCUS, 3 important things I want you to emphasize today and show you how good you will be using cardiac ultrasound. Only 3 things. You want to know, is there a problem with the preload, especially patients with hemorrhage, dehydration. So how do you identify them? In pump function, how is the LV doing? How is the RV doing? How are the valves doing? Okay, anything you look into the heart. Okay, is there a fluid around the heart? So you can see with cardiac ultrasound. Problems with afterload, I usually say it's a diagnosis of exclusion, especially anaphylaxis or anything afterload problems. It's very hard unless you know your pump function. So these are the 3 things you are specifically looking for using your cardiac ultrasound. It's very easy. You just use only 4 views of the heart to get to know, to see completely, not like a TE using 20 views. We call it as a parasternal long, parasternal start, apical 4, and subcostal. The important thing is here, as Rosie mentioned, always include your pleural views to rule out, to know what is happening around the heart. Heart and lungs go together. First and foremost view is the parasternal long axis view. So in this view, so this is the view that you get, and you tend to see the heart in the long axis, and close to the surface is the right ventricle, left atrium, aortic wall, mitral wall, and the LVOT. So this is the classic first view that you start off and use when you start doing your cardiac ultrasound. What are the things that you can easily identify just by eyeballing? Okay, I'm not going into advanced. This is a talk of hemodynamics, but I didn't deep dive, putting all the pulse wave Doppler, M modes, and everything, because it's too much on the first day. So my important thing is, you just put a probe, looking at the eyeballing, looking at each view, what can you identify? So if you look at this image on the first, you see this image, classic, what is happening. You see this, the mitral valve is not going and hitting the septum. So we call this as E-point septal separation. So this is a classic feature of a low ejection fraction. The heart is not squeezing well, there is a low EF. You see the image, you see this mitral valve motion, just fluttering, not moving and hitting the septum, you know that that's the problem of low EF. The second one in the middle, you see this image. What's happening here? You see this aortic valve here, not at all opening. So it's a thick calcified aortic valve. But just looking at the image, you know this patient has an aortic stenosis or calcified aortic valve. So you don't rush up doing a spinal with a big dose or anything. It gives you a way, how can you optimize your anesthetic, the preoperative care, and what things are needed to do the best out of these patients. What is this last one? It's very common in India. You see this mitral valve here, classic hockey stick appearance. So this is mitral stenosis. So anything with a mitral stenosis is a fixed output. You don't get a good cardiac output. It can be very dangerous if you use too much of anesthesia or anything. So just by looking at these cases, you know where we are and what is happening. You don't need to do much of the things. What are the other things you can easily identify? See this one? This is one of my cases. This is like a HOCM with a massive septal enlargement and SAM. See this mitral leaflet going and touching the septum and causing the SAM. This is the killer disease. I always say HOCM, unless you see, it is like really, really bad, because you don't even know until you scan them. The next one you see is fluid all around the heart. This is a critical cardiac tamponade. You need to act, you need to treat it very fastly. So these are the things, when you see the image, You got what is the diagnosis? What should I do? How should I act? And the beauty of point of care ultrasound is you can assess your treatments. You did something, is it working or not? It's bedside tool, just go and use. What is the last image? Okay, another thing you commonly encounter, okay, left atrial myxoma acts like a mitral stenosis, complete obstruction to the flow from the left atrium to the LV, and it's like a fixed cardiac output state. So these are all examples with just one view where you got a diagnosis and you can just know what's happening. What is the next view? We call it the parasternal short axis, because we cut the heart in the short axis to look at the LV and the RV. So this is the classic view that you get with the RV on the top and LV in the middle with the two papillary muscles. This is a good view when you are thinking of patient having hypotension. This is the one we always recommend. Put the probe, look at the squeeze. You put the finger, look how all the walls are contracting and how they are doing. So this gives you an idea how things are. If the walls are contracting too fast, you know it is an hyperdynamic. It could be due to less preload, or it could be a reduced afterload. It can be anything. So the only way we come to that point is going deep diving into left ventricular and diastolic volumes, which I'm not going through today. So if you look at this view, what is the LV doing here? It's hardly doing anything. Okay, there's a low EF. If you look at this one, it is hardly doing anything at all. Compared to the left, this is hardly doing anything. If you put your finger there, the walls are not even squeezing. These are the cases of left ventricular failure. Okay, what do you do in these cases? It's very simple. You put the probe, you see the patient with hypotension, you don't give fluids. You need to give inotropes. So it gives you a proper treatment modalities when you see the images. What is the last one? This is like a dilated big RV. If you see this, it's the most scariest echo you would ever see. Small LV, big RV, septum pushing to the left. Okay, you don't want underestimate RV. So that's another important thing I want to tell you guys. So always think about your RV. Next one is the most important, the best view I always say hard to get is the apical 4-chamber view. Okay, this is one view. You see all the 4 chambers of the heart, both the valves, tricuspid and the mitral valves, and everything. So you can see all together here. This is a classic 4-chamber view. I like a lot this view because it gives you a more intense or vast idea how the whole LV and RV is doing together. So how can just the apical 4-chamber help you out? If you look at a few examples here. So this is an example. I don't know how many has already caught an eye. So this is a thick aortic valve, not at all opening. So you put the view, it's a 5-chamber view, it's sort of, and you open, see the left aortic valve not even opening. You already made the diagnosis. And you look here, what is happening here? You look at the clot going from the RA to RV. Okay, when you are resuscitating, when the patients are in code and you get this, you know what to do next. Either you send to the IR or you start heparin or TPA. You act very immediately and fastly. What is this view? This apical 4-chamber view, left LV is not doing anything. So this is a dilated cardiomyopathy with poor EF. Again, you don't need fluids here, you need something else. So just with one view, how you can come to your sort of a diagnosis, most of the cases. Again, this apical 4-chamber, it's very easy. Heart is floating in the fluid, typical pericardial effusion with the tamponade. What is the middle one? This is another scary one, again, as I showed you in the parasternal short axis. Dilated RV, almost with a McConnell sign, okay? Classic for pulmonary PE pulmonary embolism. You don't want to see this. You see this, you need to act fast. What is the last one? Again, poor LV. See the LV, how it is dilated, not able to see. So just with combination of views or even with one views, you come to know what is happening inside the heart and how you can appropriately manage your patients. The last one is the subcostal view. I love this view because it helps into the ACLS, and most of the times people use only subcostal to identify most of the things. Again, you see all the 4 chambers using through the xiphisternum, using the liver as the window, and you can identify most of the things. Again, what you can see this nice tamponade or an effusion case. Again, with the subcostal view, you put the probe and during the CPR or post-resuscitation, you see this, patient has a low EF. Hardly you see the ventricles contracting at all. So this patient needs some help. So what is this one? Again, you see the clot from the RA to RV in the subcostal view. So you are able to make things very nicely. So our last one is, when you do the subcostal, turn the probe, look for your IVC. As a beginner, I always say IVC is good, but I don't tend to use much of an IVC. The important things to look at the IVC is, what is the size of the IVC? How is it responding? So if you look at this IVC onto the left, you see this IVC is not at all doing anything with respirations, dilated. When you see the IVC here, it is less diameter and it is spontaneously collapsing. Okay, if you see a collapsing IVC, less diameter, you know my patient might benefit from fluid. But if you see an IVC on the left with the dilated, nothing, you don't need to give any fluids. So it gives an estimate of your CVP. Basically, that's what I will say with an IVC. You can know your regional wall motion abnormalities well in advance if you use your TTE by knowing which wall. If you see the parasternal shot, this is what supplied by the anterior wall by the LAD, lateral by the circumflex, inferior by the RCA. So if you know your geographic supplies of the coronary, you can identify things. So coming to the advantages of cardiac ultrasound is, you want to know, is there a problem in the preload? How do you know? Looking at the IVC, looking at the LV, if it is hyperdynamic or end-diastolic area, or even looking at the RV. Looking at the pump, okay, is there any abnormality in the wall? Is there a flap? Is there a SAM? How is the RV? How is the LV? Is there a fluid around the heart? Afterload, as I told you, it's like a kissing or hyperdynamic ventricle and reduced and near empty and systolic. So looking at this, you can optimize your treatment, whether you need to give fluids, I need to give inotropes, or vasopressor. These are the three things. You just balance accordingly to treat your hypotension in the perioperative period. Instead of a guess game, you are straight on, bang on to the right care. What can it do? It enhances your perioperative care. Okay, it's a magic. If you use your cardiac ultrasound, you do miracles in your perioperative care, doing the right things, using less anesthetics, using the right medications, optimizing patients very well. Maybe if you need to admit, you might admit them in the ICU. So your planning goes on very, very well, these patients. So I always say, good clinical examination doesn't give you all the answers. You should use POCUS to look inside the human body, what is happening. Otherwise, you will be left crying. So we all started, anyone wants to learn POCUS, especially few societies like AFSR or anything, ASRA POCUS papers are the starting point. Everything is written, how to start, how to establish a course or career with that. So again, we do all the courses. As Rosie has told, ASRA has a POCUS spotlight. Go ASRA, put POCUS spotlight, you get all the articles written by experts worldwide. Everything is available within our ASRA society, and we do the courses. So thank you. Thank you, AFSRA, for this unique opportunity. I couldn't cover much of the advanced cardiac because it's like a 30 minutes. For me, it's always a teaser. When I talk like 30 minutes in a POCUS, it is nothing. I am talking the whole content. So sorry, and thank you all for your patience. Thank you.
Thank you so much, Dr. Kalagara. We can see why you are the chair of the POCUS program, saying so much in such a short time. And there's several compliments waiting for you in the chat. It's beautiful images and very logical approaches. We have some time for questions now. There's quite a few questions. So I'll just sort of start from the top, questions and compliments. So Saleh Abdullah from Egypt, I think, yeah, from Egypt. It is amazing lecture. What is the best way to have training in POCUS? Where should you start with training? Either of the speakers may answer.
Training in POCUS is not easy. It needs a lot of your own personal time, enthusiasm, and motivation. And one thing I always say is to learn POCUS, first you need to believe in it. If you have people with old people sitting around you, say, I have done 15 years of practice, 20 years of practice, I have done nothing happened, don't believe them. Just ignore, move
Okay.
forward. That is the key thing. So you need to see the value of POCUS, understand the value of POCUS, and first thing. Second thing is you need to have an infrastructure where which country you are, that some program to start off, courses to learn, especially always start with a course to go learn, come back, use other resources like your ICU colleagues, cardiologist, radiologist. I learn from everyone. I am still a learner. That's what I always say. I went to every department in the hospital to learn the POCUS. First, I learned from the ER, DVT, I learned from radiologists. Till now, cardiac, I learn now a lot of liver and renal ultrasound. I go to the sonographers. Please extend your areas, use the ICU colleagues, and use the ASRA papers, how to do, when we're doing a POCUS, what are the key things to look, okay? How many need to be scanned, to certify and everything like that. It's a long process, but in short, you need to motivate yourself, go to a course, get your colleagues, or use online resources. Especially online resources are amazing. You may not be seeing all the pathology all the time. The only way I see a pathology is if I share something on a social media or somewhere, I tend to live. That's why if you follow me on Twitter, you'll see everything on POCUS. I shouldn't say, but I'm telling you.
Yeah,
Yes.
Sorry, I completely agree with everything that Harry's saying. I think the thing you have to be is a constant learner. I love, if I'm in the interventional radiology suite, the number of times I'll be saying to the radiologist, hang on a minute, show me what you're doing. And the other thing you have to remember is give yourself a break, especially when you're learning cardiac POCUS, because you'll go to a course and we have these wonderful models and everything looks amazing. And then you'll go back and you'll scan your first patient and you won't be able to see anything. But I want you to remember that, look, next time you have a patient with an echo, look at what the echocardiographer has written: challenging views, difficult images. So give yourself a little bit of a break. The other thing I would say is if you have patients in your ICU or in the ED that have pathology, so if somebody has already been diagnosed with a pleural effusion or something like that, go and scan those patients, because especially, or somebody, if they've got aortic stenosis, once go and scan them and see what that looks like, because once you scan that pathology a few times, it's stuck in your head. And the other thing I would say is scan every patient that you anesthetize. When I was learning, Harry and I, again, we've taught so much of this to ourselves and to each other and this sort of thing. We just scan everybody. I say to all my patients, oh, you're going to wake up with gels here or here. But once you see normal, lots of times abnormal becomes really obvious.
So there's a question later on what is the minimum criteria that you would recommend before you should be doing this in theatre? In other words, can you do harm if you don't know anything? What would you say? Should we just be scanning everyone, even if you know nothing? Or should we have, should people have fulfill a minimum criteria before they can?
It's a difference between a competence, billing, and learning. To learn, you have to scan everyone. To make a diagnosis and treat what you have seen, then you need to be a little bit competent and expert. So then you need a minimum number, like we say 50 for all these other modalities and 150 for cardiacs. So without competency, what happens is if you do things, then I'm worried my POCUS will get a bad name because you're not doing the right things. So to do the right things, scan everyone, but get a helper, someone who is like good. If I am in the hospital, because people want to learn, I am there like that. Use your other people who are good, then scan everyone, then move forward. But without expertise, don't, please.
Okay, so you're saying scan everyone, but don't take decisions on it before you know what you're doing.
Yes.
Okay.
Yeah, and I think when you think about regional, when you think about regional anesthesia as well, when you first started to learn regional anesthesia, you probably kept using your nerve stimulator as well, but you were looking for those things. So don't expect to be perfect straight away, but keep scanning, and then you've still got all your other clinical skills. What I say to people is, remember that if you don't scan, that you don't know anything else. Whereas, if you do scan, you may learn something more. This is not to replace your stethoscope, your clinical skills, but this is just that added bit of information.
Mm-hmm. I think that's the answer, yes. There's people asking how they can attend your clinical rounds, Dr. Kalagara. Will you maybe at some stage just write it on your write it down and share your screen so that people can see where to, or write it in the chat. If you can maybe write in the chat. Where people can.
Tomorrow's grand rounds talk is a very interesting, exciting one on GLP-1. Unfortunately, I was told not to share outside the link for the live, but I will share the recorded to everyone. So we may not be able to see the live tomorrow because of some patient issues, because I'm presenting some cases. So I will definitely get the recording to everyone. It will be everyone.
Where will you share it?
Yes, I will share it. I will send it to you, and I will share it on the social media. If you follow me on X at the rate of my Twitter handle, you'll get the recording soon.
Okay, fantastic. So now everyone knows to follow your Twitter handle. All right. One of the major limitations for the use of POCUS in Africa is availability of portable ultrasound. Do you have any experience in how to get the equipment in terms of maybe partnerships with manufacturers or anything like that? There's another question also for how do we get to learn POCUS in an under-resourced environment?
It's always a challenge. Initially, when we used to do like 3-4 years or 5-6 years back, the biggest barrier for this POCUS was ultrasound machines. Now, when I go to India, that is my luxury now. Things have completely changed in the 4 to 5 years of span. Okay, you won't believe how things are changing. Especially with the portable devices, it's getting a game changer. Okay, cost is less. Especially, I am not here to speak for any company or anything. So I'm just telling, it's a butterfly. Cost like 1/3 of the price of anything, is really good for basic things. I may not be saying this is the best tool for a cardiac ultrasound, plastic ultrasound, doing peripheral nerve blocks, doing peripheral IV access, doing basic stuff. That's really good enough. 2,000 grants, you get a butterfly. You can use at bedside, anywhere in the operating room. You can share with your colleagues. It's not one people. 5 of you combine together, put some money, buy one machine. That's a starting point. And some of the new ones, like portable ones like GE, Philips. I use Philips a lot. It beats a machine. Outstanding imaging quality. But I'm not here to tell those things, but I'm telling. So lack of money, financially, go for portable, good starting point. Pick the ones that you can afford. What important is scan whatever you have. I always say, if you have a difficult machine, sometimes it teaches you very well.
So do you think it is...
Yes. Sorry to keep on. I would say approach a lot of the manufacturers. A lot of the manufacturers are really keen to work with low middle income countries. There's other machines, that people are donating, so that there are a number of schemes that are trying to get ultrasound out across worldwide, because we understand how important these machines are for clinical practice everywhere and how easy they are sort of to maintain as well. So reach out to any of these companies. They all do have schemes to try and get ultrasound machines across the world. So definitely reach out and ask them.
Yeah, I have the same experience. Do you think that it is something that is cost effective, that one can convince a hospital to buy it, that eventually they will save by buying ultrasound machines? Or is it something that the anesthesiologist should just buy for themselves in a group, maybe share one machine?
That's a good thing, Franco. Maybe from the American perspective, we always look money, dollars, business. So that's a common question people ask me. But now we scan, now we bill almost everything. We get money out of every POCUS we do. Gastric ultrasound, we bill, right? And we make money. So that's a good incentive. What I always say is, don't worry about the business perspective. Look at the patient outcomes. Look at the things that you can do with the powerful tool that you have in hand. Okay, if somebody is going to invest something that changes your perioperative care or anything in this era, there's nothing other than the ultrasound. Nothing, I'm telling you.
Yeah. So what I can say is I've got my own, I bought my own, or got my own one, and it makes a huge difference having it with you all the time, if you can, in any way, because you will see, I agree, you will see the difference in patient outcomes. Is there anything like Plan A POCUS? Where should people start? Is the next question.
So for me, what I always say to people is start with the POCUS that will influence your clinical practice the most. So if you're working somewhere where you now are seeing lots of people with GLP-1 agonists, you need to learn gastric POCUS today. It's so important. If you're working somewhere where you've got a lot of trauma, you're going to need to be looking for lung POCUS. It's learn the POCUS that works for your practice. If you're concerned, if you're worried about where to start, I always tell people to start with gastric. It is incredibly easy to learn. You're only looking in one area. That's why cardiac can be sometimes a little bit more challenging. But honestly, once you start scanning one, start doing lung as well. Lung is so unbelievably useful. We demonstrated there, you've got 7 or 8 differential diagnoses. So I would say rather than thinking, oh my goodness, which one of these, you can POCUS anything. Like, you can POCUS the body from head to toe. And the POCUS that we do is not different from the POCUS that the ED physicians do or the intensive care physicians do, but you choose the POCUS that is most important to your clinical practice.
Okay. There's another question that's actually been answered. How reliable is portable scanners? So everyone thinks it is very reliable. So I'm just looking at that. Was the questions from the Q&A? Yes.
Franco, somebody I think looking for what is the best e-learning module or something. I saw a question. I would say anyone wants to learn POCUS, USABCD is the best e-learning module. I don't hesitate advocating for them. Anyone, or if, for AFSRA, if it is money is an issue, if you coordinate with them, they even give you some modules free. Okay, for gastric, they might give you free. Lung, they might give you free. One of the best resources to learn is usabcd.com. Use it, learn it. Yeah.
I totally agree. Yes, I totally agree. And for the audience, just USABCD, ultrasoundabcd.com, and you will find it. And many of the courses are free. Some you can buy, and we are looking at maybe getting a discount for Africa via ESRA, but that's still coming.
Sorry, Francois, just to interrupt.
Yes.
USABCD is free if you're an ESRA member. You will get access to USABCD, and it's usabcd.org. I've just popped it into I've just popped it into the thing there. But gastric is always free, airway is always free. So they already have a number of free modules as well. But again, Harry brought up as well, POCUS Spotlight with ASRA is just absolutely fantastic. Honestly, you will get the most up-to-date thing. The videos are really amazing. And gastricultrasound.org, there is literally nowhere better to go for gastric ultrasound teaching as well. But again, as Harry said, go on to X. Honestly, if you type hashtag POCUS, you will get so many fantastic images.
Thank you. Yes, got the same experience. Okay, I think there's lots of compliments in the chat for the 2 speakers. I think that's all the questions we have.
I think there is a tough question, Franco, there. One question I saw, can we have Dr. Rosie and Hari in Africa live next year?
Yes, and?
Oh dear. Harry, you'd have to go home for 5 minutes. There's nobody more well-traveled than Dr. Gallagher.
Yeah, for sure.
So this is the only weekend I thought I am at home, but again I was busy with this conference and the grand rounds. And next week I'm going to India. Oh my God, it's crazy. But always happy, Franco, Mohammed, especially for the low resource income or anything. We love going, training, teaching. We always partner with ASRA, and much more good news will be coming in ASRA POCUS also soon. We'll all tell you.
We will definitely use you again. Thank you so much.
We are discussing with Dr. Mocha, so a lot of things will be coming up with Rosie.
Yes, that's right. So, fantastic. Yeah. Well, Rosie and Tari, thank you so much for joining us. Thank you for sharing your expertise, for teaching us so much, and your willingness to participate again. It was good to see you.
Thank
Okay,
you.
love to
Thank you.
see
I
you
also
too.
say it's
Night,
just a
everybody.
teaser. Please come back. Please learn. It's just a teaser
Yeah.
we did today.
Yeah,
Thank
absolutely.
you.
We could talk for another 4 hours. So lovely
We
to see you all.
could, we
Take
could.
care.
And
Bye.
next time I should
Thank
go
you.
before
Bye.
Rosie.
Bye,
Thank
guys.
you. Thank you, Frank.
Bye-bye. Thank you.